Good morning. Happy New Year. Happy 2024. So glad that you all could join us today for the Louisville Metro Opioid Settlement Distribution Advisory Board meeting. I am Connie Mendel, serving as Director and Chief Health Strategist or Interim Chief Health Strategist for Metro Louisville Public Health and Wellness. I'm joined by my co-chair, Dr. Ender Single, who will be helping today with orchestrating running the meeting. So I'm glad you all could join us today. Um, it's been a really exciting time for us as we had put out the request for applications for spending the opioid settlement dollars. We have 5.3 million at this point. So thank you to the board for coming together. We did receive about 60 applications, so very exciting. Really, just it shows you a testament of just really good work and planning that's going on in our community right now. I wanted to introduce some of the internal Louisville Metro Public Health and Wellness staff who have worked diligently with us and on these applications through sorting and organizing and new staff. So I wanted to go ahead and introduce Ben Goldman and Michael Surfrant. They have done the yeoman's share of work as far as compiling and sorting and thoroughly reviewing all of the applications. And then our new staff member, Kalisha Comley. Hi, welcome. She will be spending a lot of her time working with us in the following months as far as particularly when the applications are awarded and working with the organizations and entities, making sure that they're able to meet those objectives and those listed. So welcome. All right. So I just wanted to go over some of the information that you've been receiving. So you should all now have access to all of the applications. Um, and if not, please reach out immediately if you had any issues with accessing those. We, again, our internal team did go through those. There were some applications that that do not meet the RFA and the requirements or were incomplete, although that is a small portion of those, I think um, about 7. So still leaves us with many applications. And again, we're really excited about the work. And even those that may not necessarily meet this RFA, we're reviewing those and hoping to connect a lot of those applications to other organizations, potentially other grants or other program areas. They may not have been specifically for the opioid use um, and those suffering from substance use disorders. So we'll work closely with them in the future and hopefully other opportunities for those. Um, so with that, um, everyone has been provided a spreadsheet that lists the applications, um, their initial assessment as far as recommended or highly recommended, or those that are not recommended for the reasons I had mentioned. And then also breaking those down into the different categories as we specifically look to fund projects with primary prevention or access to treatment and or supportive recovery and particularly housing. So those are listed along with the budgets for each. We will say under review, there were not as many applications that we had hoped to see for prevention. That was one of the goals of the RFAs, and particularly Metro Council was very interested in sponsoring and moving forward with primary prevention. Although there are a few, but the majority of them did have projects that, when we recovery support. So we are looking to spend more time, attention, and funding as far as primary prevention. So moving forward, at this point with this round, we may not, or we're considering not funding the entire 5.3. We may hold back some of that funding to get to what we think is more substantial um, work around primary prevention. So with that, and Dr. Single, did you have comments to add to that?
Thank you, Connie, and thank you, everyone. Happy New Year to everyone. I agree. The very first distribution that we made late last year was for quick response and saving lives. This large sum that we have, we were hoping that we use this. We were following Johns Hopkins model, which is long-term recovery, housing, and then primary prevention. So a lot of the RFAs, and it's amazing to see these RFAs. It's amazing to see all the community work that's being done in our city by so many good people. So it's pretty heartwarming. When Connie mentioned that there were not that many primary prevention, that's true, although there were some secondary prevention, long-term recovery within the same RFA. So what we ask of you is review these with us, and our options are we distribute as is. If you all feel strongly, this will give us the best return on investment. 50 plus $1 million sounds a lot of money, but when you really think through the work that we need to do in this community, it's not that much. And also remember, the first year distribution is the highest dollar amount, and then each year, subsequent year, it sort of decreases. So our ability to make a larger impact will continue to dwindle. So we have to be very conscientious how we spend this money. So our options are distribute all this as is, or we withhold a little bit of money and then go to our community large donors, ask them to match that money and fund primary prevention programs, go and scout primary prevention programs, or some other mixed option, and we're open to hearing the board's advice.
Yeah. And I do want to clarify, it's 5.3 million. Okay. Because I thought I had misunderstood. I thought you may have said 50 million. So, okay. So,
Connie, you're muted.
sorry. With that, I wanted to give Ben and Michael an opportunity to speak of the high level review, or actually, you all did a very thorough review, but what you created with the spreadsheets and those levels, and what you just an overall summary.
Sure. So we basically did two different evaluations, two cuts. The first, as Connie mentioned, was merely for eligibility. So just ruling out any of the applicants that we thought either would not be able to be funded using this funding stream, or that there would be some issues with the expenses that they were proposing falling directly under addressing opioid use disorder. The guidance that we've gotten, both from county attorney's office and OMB, is that the goal is to really make sure that we are as clear as possible that every single piece of work associated with spending these settlement dollars is directly tied to opioid use or opioid use disorder. So while some of the interventions may address a host of community and social issues, or may address a host of substance use disorders, the goal is for all of these to focus on opioid use disorder. Another area that we're using for exclusion is the lack of the evidence base. So one of the pieces of the proposal that we asked for, or the applications, was that people cite an evidence base, ideally peer-reviewed journal article. The guidance is to, at minimum, have evidence-informed approaches, but the gold standard is to have solid evidence base for any tactics that you're using with this funding. Um, and then obviously, if people didn't complete the application, one of the applicants just submitted their name, and that was inadequate. So that was sort of the eligibility piece where we could say pretty safely, this may be good work. It may be something that we can work with the organization to modify in the future, either for an application with future abatement funds or other grants and foundation money. But for this round, the current application as it stands would not be eligible for funding. That was actually the easier of the two cuts. The second one was around public health impact, and that had a number of criteria involved. There were the main goals of the request for application, specifically around primary prevention, access to treatment, recovery support, and housing. A lot of the applications were opioid use disorder related or were opioid related, but they were not within those kind of priorities that were set out in the RFA. So that didn't exclude somebody, but when we were evaluating sort of within the recommendation, the under consideration, and the not recommended, that played a role. And then the other areas that we looked at were sort of how the narrative fit the needs of the community and identified and addressed the gaps, focusing also on looking at what the budget activities and sort of the funded components of work that were being proposed, how those aligned with the narrative of what the hoped for outcomes would be. As I mentioned before, with evidence base, there were some applicants where they cited an evidence base, but then the work they were proposing wasn't actually related to that evidence base, or we couldn't see a direct tie between the interventions they were proposing and the evidence base that they were citing. And then really looking at the scale of who is being impacted, whether the people being impacted are sort of the highest risk folks or people who are disproportionately impacted by opioid use, opioid overdose, and opioid use disorder. And we didn't do a formal cost benefit analysis, but just looking at sort of the scale of funds requested relative to the number of people served, to get a rough sense of what the return on investment was. That's something that we've received guidance both in this body, and then we've heard from council that that's something that they do focus on. So it was something we paid close attention to in our evaluation for public health impact. Michael, is there anything you would add to that, or anything I'm leaving out?
I don't believe so. Well, one other thing we looked for was that the application or the work proposed focused on Jefferson County and Louisville area. But aside from that, Ben, I think that was a great rundown. Thank you.
Mhm. Thank you. Thank you again for the incredible amount of work and thoroughness that you all applied to this. And Dr. Single, did you have a comment?
Oh, thank you again, Ben and Michael did a great job. The only other comment I will make to the board, even though we have sort of done this work, initial work, is not final by any means. We rely on you all. We have provided you all these RFAs, and this is not written in stone. We are willing to move around, and that's the discussion that we should have as a group.
So the expectations for the board moving forward, you have score sheets, and you have access to the complete applications, all and all 58 of those, to review those and score. And then we will work forward, moving forward, as reviewing all of those scores, putting together, compiling that information, and then we'll meet as a board to determine which ones were to be awarded. And it's crucial to remember, and I think everyone is aware, but you know, looking at the app, because there are many, like I had mentioned earlier, many really good applications of work being done at multiple entities in the community. But again, referring back to those application priorities, and also ensuring that it meets the requirements of spending the funds. So when we look at our local priorities and then those of the settlement, and particularly looking at sustainability, is it directly impacting those with opioid use disorder? Um, and is this for new initiatives and not just continuing on services that are going, actually bringing new people into treatment or recovery, and looking at primary prevention. So all of those, everyone has the information of what the priorities are, how the funds can be used. So with that, I wanted to give the board an opportunity for questions, discussions.
I will add one more thing. I think before our next board meeting, the other thing board should review and consider, hey, if these RFAs are good and that our focus for this year or this distribution should just be long-term recovery and housing and not so much prevention, or should we withhold some funds that we don't distribute and that are allocated towards primary prevention, and how much those funds should be, if we're going to do that. Any questions?
I have a couple questions. My first question is, when we do our scoring, are we only scoring the ones that have been recommended from the Excel sheet, or should we all still look at all of them and score everything?
Yeah. Other than those that have been removed consideration for not meeting the application parameters, I would encourage you to review all of them. As far as scoring, that it, that's your decision. You're not required to score all of them, but I would recommend reviewing everything in, if you look, they're color coded. So I would say, in the darker green and the lighter green, and then the mauve color, that that's up to your discretion.
So we are scoring everything that says included and not scoring only the ones that say not included. Is that correct?
Correct.
Okay. And then my other question is for the group, like, are we trying to kind of separate how much money we want to allocate to specific focus, like we're talking about like prevention or housing? are we wanting to kind of stay within, 20% is for this focus, 30, something like that, or we're not creating any kind of like focus like that?
I'll take that. I think that's such a tricky sort of subject because when you look at John Hopkins' guidance, they didn't really go into details. Their focus was housing, long-term recovery, and primary prevention. We know that primary prevention is what's going to give us long-term results. We're not going to see the results, as Ben pointed out, today or next year or in the year after. But if we're trying to solve this problem that we know is an epidemic, then it has to be a strategic plan, and the strategic plan demands prevention, focus on prevention, primary prevention. So it's very difficult, when you see something in front of you that you want to fix and you want to allocate dollars to that problem and not be able to focus on 10 years down the road. So it's sort of a tricky subject. That's why we're asking your guidance too. We know that there's such a need right now. We have a lot of population that requires immediate help with long-term recovery and housing. So we're going to end up spending more dollars towards it. Then we can carve out small amount of dollars, and then we can go to community donors, as Deputy Mayor pointed out, and plead to them to match those funds to make them more robust of a distribution. So there's no fixed number. I know it's a long answer, but there's no exact guidance either.
So I see Councilman Baker has a question.
Hey, good morning, everybody. Not really a question, but a statement from the council. I mean, you stated before. I don't know what those dollars look like to hold back, but there should be a robust focus on that primary prevention as well. And so I don't know. Again, it's up to us collectively to decide. I would lean on either looking at the John Hopkins model, taking closer like what percentage or how they built it out, but I just want to stress those two tiers and echo the sentiment of making sure that we're doing the recovery support, but we're also doing that primary prevention as a representative from council. Thank you.
Thank you very much for that. And we do have several
Thank you.
very good applications related to primary prevention, and there are others with secondary prevention. So in treating maybe the parent with the opioid disorder, subsequently their children would hopefully be prevented um, from addiction or an opioid or other disorder. So
Quick, quick
go ahead.
question. Quick question while we're on that subject. In those that we've identified from 37 to 58, with the exception of the 7 that we've excluded, do any of those, when we're saying we're working with them to get them to a green status, we'll just say, do any of them have primary prevention bandwidth that they've already built out, or is it just something that they have left out of the proposal, or something that they thought they were doing the application, but they would be open to providing that for this grant or for these dollars? Do we know?
Yeah, so at this point, we've not reached out to any of the
Okay.
applicants. We're just reviewing what has been submitted.
Okay. Thank you.
I would add, just from the perspective of capacity, that is something that we've kind of highlighted in the past as a department, that our community in that continuum of care and all of the different areas around dealing with substance use disorder, the prevention area is where our community lacks the most capacity. We have good partners who are doing it. But in terms of the best practices, really the ideal is a large scale, top down set of interventions based in the schools, and then a really robust set of youth development programming, and really not focused exclusively on opioid use disorder, but just identifying more opportunities to have that social emotional learning for young people, opportunities for pro-social connections. And as Dr. Single said, that's often harder to fund at scale because the payoff for that is so far down the line. Whereas, I can spend $41 on a unit of Narcan and know that it's likely to save a life in the next month. So I think one of the things we've talked about internally too is really making sure that part of the work of this advisory council and our department in using these funds is to help build capacity for larger investments in the future around prevention, because we have so many organizations that submitted proposals specifically to do access to treatment and linkage to services for people in active use. That's something we have pretty good infrastructure around. But there was nobody who submitted sort of a similarly scaled prevention. There are a lot of good smaller proposals, and we've recommended most of those. But I think in terms of what we'd really need to see in this community is bigger than the opioid abatement settlement.
No, I completely
Thank you,
agree.
Ben.
So thank you for that. My day job before as a councilman, I'm also a family resource coordinator at JCPS. So I completely get what you're talking about with the social emotional. And so with that being said, I just again want to stress we might want to, even though they weren't the initial applicants, but just whatever we collectively decide, setting aside or holding back a certain dollar amount for those who can build out that work, because it's important through an equity lens. So I just want to put that on there too.
Yeah, absolutely.
Yeah.
Thank you. And we do want to say, this is a new process for us, relatively new. So we are learning with each step. So, as a health department, as even as a board moving forward, as we evaluate the applications, we're learning how to better streamline or better prioritize and ask the important questions. And as you'll soon discover in reviewing these applications, some of them are very thorough when we talk about impacts and data and how they're going to track the work that's being done, and others not so much. So for some of these organizations, we may recommend them seeking assistance, or even how we can work with them further, to further explain the work that they're doing, or quantify the expectations. So and we have, as a board, we have the opportunity to hold back what that, if it's $2 million, to say that this needs to go towards primary prevention, and be more specific as far as application requirements. Yes, Mr. Allen.
Yes, Barry, please. Um, So I guess just to make sure I understand, so all we're doing now is scoring. We're not getting into funding, correct? In other words, we're just scoring.
Yeah, yeah,
Yeah.
yeah.
And so we do that manually, in other words, or is, I maybe not looked at the site well enough, or is that something we do online with each applicant?
That's something that you would do, I guess, manually, or
Yeah, okay.
recording the information on the spreadsheet,
Yeah,
and returning that to us, and we'll compile all of the
yeah,
numbers.
okay.
Yeah, we don't, we're not, sorry, it's technologically advanced.
No, that's no problem. I just
The
want to make
online
sure I
scoring.
didn't miss something there. Yeah.
Yeah,
Okay.
but wouldn't that be great?
Yeah. And do we have a date by which you may have said that and I missed it? You want it back?
Mm. Well, that's we want to be reasonable, but also understanding reasonable with your time and also with the expectations for the community. So that's part of the discussion we're getting to now is what would 2 weeks be a reasonable time for this board to review the applicants or the applications? Okay, I see a couple of head nods. Okay, fantastic. So we great. So we'll set a 2-week deadline, and then we will also send out a doodle poll for a subsequent meeting.
Is it possible also within that 2 weeks to think through, is there a specific dollar amount that you guys recommend, or you look at us for recommending a dollar amount that you all then sort of agree or chime in as to how you feel? Or primary prevention, I meant. Sorry.
I don't know that I can adequately answer that, Dr. Single, but I took note of what Councilman Baker said earlier. Like, is there something that was outlined in the John Hopkins model that could give some indication of, what amount, is meaningful to carve out for primary prevention, recognizing all the things that have been discussed in terms of it's a longer term game. I understand all of that. I think that would be a good starting point for us to just have something to reference to begin even leaning into that conversation. I mean, even considering just the sheer number of applications that we've gotten across the different categories, I mean, 28 million already far outweighs what we have available. So after we get through this initial scoring piece, we're going to have to come back and just have some conversation around how are we considering these different categories and looking at the various thresholds. I mean, I feel like our work is just beginning. Scoring's kind of, we've got our work cut out for us, right, gang?
Absolutely. Absolutely. Yeah. And that's another fear that I have. If we carve out a huge amount,
Right.
actually that dilutes the impact of the long-term recovery and housing too. So that's why I was saying there are multiple different ways to think this through. One was that we allocate all these dollars to long-term recovery and housing with some primary prevention sprinkled within and secondary prevention sprinkled in this distribution. And then we say hey, the next distribution, which is we will know the dollar amount in the next, Taylor will probably have an idea in the next month or so, whatever the 2024 distribution, then we say, hey, all the 2024 distributions will go towards primary prevention. But then are we leaving some of this good work unfunded for the next round? So it's this very complex process, as you said, Adria, but or do we just carve out a small amount and then go to community donors, ask them to sort of match and boost that number? So I agree with you. Barry?
Well, so again, let me just use as an example, let's take the very first one on the list is Beacon House. So they've applied for 114,000 plus. So my question is, I guess when we get around to talking about funding, I'm going to assume that that number is a legitimate number, that I shouldn't be, thinking about, that. And that if they fall high enough in the priority, that they're going to get all $114,000. So is that the way we should be thinking about this? Or are we looking at this and saying, well, we're going to give them all 50%, of the dollars we got available, which means they probably can't do, the project. So just give me a little guidance there as we think about, getting down to, actually providing funding. Is my assumption correct or incorrect?
No, you're correct. And I think you should consider this, that we will fund completely. Now, unless as we're reviewing this, we find some discrepancies. So there was an RFA when I reviewed, when I looked at their ask and looked at the numbers that each RFA has a budget. If you look at it, there are numbers, dollar numbers, and the staff or how they're using it. Those numbers didn't add up. So unless something like that, there's a numerical error, we should fund the whole project. If we believe in that project, not funding the whole project will not make any impact, neither here nor there. Ben, you can chime in, or Michael. Am I correct in saying that?
Yeah, because we're using the RFA process, we are a little bit more free than some of the other procurement processes where it's binary, where there's nothing prohibiting us from collaborating with applicants and trying to scale down or up what they're asking for. I think the only complicating factor is, as Dr. Single said, some of them, if you fund it, a certain level, they may not be able to do the work that you're hoping that they'd be able to do. And then I would also just put in at this point, if a reminder that if we could avoid naming any of the particular applicants we're trying to maintain that level of discretion. No worries, but I know it's easy to slip up, so I wanted to put in another word for that. Thank you.
Thank you.
So
And
if I may just say, as a participant, one of the strategies I'll be taking so as not to get overwhelmed is just to really stay focused on the scores first, and to really be able to focus on the service delivery, the gap that it fills, the sustainability, all the components that Ben mentioned, and then be able to go back to see, when we talk about the overall funding, what Councilman Baker referenced, which, do we see a portion of work that could be scaled up that includes more primary prevention? But I think first and foremost for me, my strategy will be just to stay very focused on the scores and reviewing really the program details so as not to get overwhelmed around carving up dollars and holding out money and that sort of thing. I think it just makes, for me as a reviewer, it makes it a little cleaner and helps me kind of dig in.
yeah, and I did want to go back to Adria's question as far as, does the Robert Wood Johnson Foundation specifically talk about, or John Hopkins, sorry, wrong foundation. How percentages should be laid out. And not because, we need to meet the needs of our community. So, and you all are uniquely positioned to know aspects of the community and what our greatest needs are, or what the needs of those that are suffering most from opioid use disorder, or those that could potentially, as far as prevention. So that's, I think, one of the reasons that it's not prescriptive, and that every community is different. And
You muted.
yes, sorry, thank you. So on those scoring sheets, those will be forwarded to Arlena Glenn, um, who um, who most of your communication it comes from, but we will send you, make sure we'll send you a follow-up email after this meeting with the deadline and where to submit those to. I guess. Any other questions or comments?
I do have a comment. Just want to say thanks for everybody who put work together. This binder of applications has been my Bible for the new year. So just want to say thank you all to all the work that you.
And we want to say
Happy
thank
New
you.
Year.
Happy New Year. We want to say thank you to the work that you were undertaking. So this certainly will be life-changing for some of our residents. So thank you,
Absolutely.
yeah, for your commitment to doing this work, and we will meet again soon. We'll send out that doodle poll.
Thank you, everyone, and Happy New Year.